Yes, this is Bruce Chabner, and I welcome everyone to the colloquium. Today we have our third presentation on translational oncology, and it will be introduced by my great friend and colleague, Aparna Parikh from our GI Oncology unit.
Thank you so much, Dr. Chabner, for the introduction. Welcome, everyone, to this morning's session. Thank you for joining us at the Chabner Colloquium, the MAP series. As Dr. Chabner mentioned, I'm Dr. Aparna Parikh from MGH, and I'll serve as the moderator for today's discussion. We have a great session lined up for you today, which will include a presentation by Dr. Dejan Jurek, followed by a debate by Dr. Ryan Corcoran and Dr. John Iafrate. Before we begin, I would just like to thank our sponsors today, Novartis Pharmaceuticals, as well as Regeneron and Sanofi Genzyme, for providing educational grant support for this series. I'd also like to acknowledge Dr. Aditya Bardia, who's the MAP series co-chair, and the MGH for collaborating with Dr. Chabner and the STO on the development of this series. And we are especially grateful to the presenters for their participation. Additionally, I encourage you to visit our exhibit hall, which you can access in the timeline on the main event page to learn more about each of our generous supporters, including AstraZeneca, Foundation Medicine, Genentech, Novartis, Pfizer, and Takeda. The sponsors have posted informational brochures and videos for you to download and view at your discretion. In addition, you may also set up a chat with the representative if you'd like. Information was emailed to the attendees with the details about how to receive CME credit for this event. And without further delay, I would like to introduce Dr. Dejan Jurek, who's presenting on targeting the PI3 kinase pathway. Immediately following Dr. Jurek's presentation, we'll host a Q&A with him live. At any time during the presentation, if you'd like to submit a chat or a question, I'll be monitoring the chat function of this platform, so please use that to post your inquiry. Following Dr. Jurek's presentation and Q&A, we'll engage in a lively debate with Dr. Corcoran and Dr. Iafrate, discussing plasma versus tissue genotyping. And Dr. Corcoran will defend the plasma approach, and Dr. Iafrate will support the pro-tissue approach. Again, questions can be submitted at any time. Please note that microphones for all the attendees are automatically muted. So again, please submit your questions in the chat function. So without further delay, let's get started with today's session with Dr. Jurek. Thank you.
Hello, everyone. My name is Dan Jurek. I'm a medical oncologist at the MGH Cancer Center. I'm director of the Tremere Center for Targeted Therapies. And today, it's my pleasure to talk about my favorite topic, which is targeting PI3 kinase pathway in advanced solid tumors, particularly metastatic breast cancer. Here are my disclosures. I'm receiving scientific advisory board fees and research funding from these companies. We have 3 learning objectives today for this presentation, starting with understanding the role of PI3 kinase pathway in cancer biology, understanding the clinical impact of available therapeutic options targeting this pathway. We'll then move on to learning about tissue and plasma-based testing strategies for PI3 kinase pathway activating mutations. And finally, we'll focus on common adverse events associated with PI3 kinase pathway inhibitors and their management. In this schematic overview of the PI3 kinase pathway, you can see how PI3 kinase is strategically located right in the middle of the cell, transmitting messages from the outside of the cancer cells, particularly activated receptor tyrosine kinases, and then pushing that message down towards cell cycle regulators and transcriptional regulators. The pathway itself is often shown in this linear fashion, where a message goes to PI3 kinase itself, then to the AKT, then to the mTOR, and finally to these downstream effects. But it should be noted that the whole system is more akin to a network, where each node is interconnected with many other signaling nodes in the cell. I have simplified this interconnected nature of the pathway by showing this triangle. In metastatic breast cancer, the 3 nodes that truly are important for regulation of growth and survival of these cells are the PI3 kinase pathway itself, and the top of this triangle, estrogen receptor, as well as CDK4/6 RB axis. Everything we do to these cancer cells, we should always think as a series of reactions that can occur when you inhibit one component of this or one angle of this triangle. So if we do something to the estrogen receptor, the PI3K CDK4/6 axis will get activated, or vice versa. If we inhibit just the PI3 kinase, we'll often have upregulation of estrogen receptor. This dynamic nature of the signaling networks in cells is one of the main reasons why we have to deploy combination strategies for these tumors. The first attempt to target this pathway was the use of everolimus in combination with exemestane in postmenopausal women with HR-positive advanced breast cancer, where addition of everolimus to exemestane resulted in significant and clinically meaningful prolongation of the progression-free survival in the experimental arm compared to control arm, which was just exemestane with placebo. However, as seen on the right, everolimus has considerable side effects, including stomatitis, rash, fatigue, and others. And considerable amount of work has been put into additional therapeutic strategy that we can deploy to target this pathway, including development PI3 kinase alpha inhibitors, as well as AKT inhibitors. And the rest of the presentation will focus on those two targets. The very trial that we just discussed, BOLERO-2, has also shown how common activating mutations in PIK3CA are. PIK3CA is the gene that encodes the catalytic subunit of PI3 kinase pathway, and anywhere between 40 or even in some serious, even more patients will have activating mutation in PIK3CA. Similar results have been shown in the analysis of the Cancer Genome Atlas sample set and many others. As shown here, PIK3CA is actually the most common actionable alteration in this disease. It's not surprising that a lot of work and a lot of effort has been invested in developing PI3 kinase inhibitors themselves. This is how PI3 kinase looks like. It should be noted there are 4 isoforms that we should pay attention to: alpha, beta, gamma, and delta. They have different roles in normal and cancer cells. It is the alpha isoform that's activated by virtue of these PIK3CA mutations, while beta isoform is often activated through other alterations such as PTEN loss, but it's also ubiquitously expressed in normal cells. And finally, gamma and delta play a role in immune regulation. The protein itself looks like this kidney-shaped structure, and mutations in the actual gene are translated then in changes in the structure of the alpha subunit itself, which then results in changes in interaction of this subunit with the regulatory subunit called P85, shown green on the right upper schematic of the enzymatic complex. And when the mutation occurs, there is a change in this interaction and also in the change in the localization of P110 alpha at the membrane where it does its function. What should be noted that the mutations themselves do not necessarily dramatically change basal activity of the enzyme. This is really, really important. It is when the cells are further stimulated by presence of growth factors or other interactions. In that stimulated state, it's when the PIK3CA mutation truly then results in a pathway going into hyperdrive. So if I were to use an analogy, mutations in PIK3CA, it's almost like a loose gas pedal on the car. Something still needs to push that gas pedal, but the fact that it's loose, even minor sort of changes or input into the system result in massive activation of the pathway. In some models, as shown here in the upper portion of this slide, it's sufficient for cells to acquire just the PIK3CA mutation. So in this particular study, overexpression of mutant PIK3CA results in massive induction of mammary tumors, and the mice ultimately die from this alteration. But in other studies, such as this study in ovarian cancer cell models, you need two alterations. You need PIK3CA mutation and another event, in this case, PTEN, to truly activate the pathway and result in tumorigenesis. So we have to, from this very slide, remember that PI3 kinase mutations and their effect on the cancer cells is highly context dependent. In some instances, through this beautiful work recently published in Science by Neil Vassan, the two events that I'm talking about actually happen in this very same gene. So they're so-called double mutant tumors where two PIK3CA mutations cooperate to activate the pathway fully. And it may be that precisely these double mutant tumors are uniquely sensitive to PI3 kinase alpha inhibitors. We'll have to see through additional work whether that's true. But the context dependency and commutational profile of tumors is something that's essential for our understanding how to deploy PI3 kinase inhibitors in these tumors. Because in breast cancer, that mutation profile may look one way, in colon cancer may look another way. In breast cancer, it may be the interplay between PI3 kinase and estrogen receptor that matters. In colon cancer, it's the interplay between PI3 kinase and KRAS and the MAP kinase pathway. So the first PI3 kinase alpha inhibitor, the first agent that selectively blocks the very isoform that's altered by this PIK3CA mutation, is this agent, which used to be called BY719, and now it's approved as alpelisib. Already in these early studies on cell lines, it was clear that alpelisib displays preferential sensitivity or preferential activity in PIK3CA mutated cell lines. These cell lines were shown on the left portion of this slide. 74% of them that have the mutation will have significant growth inhibition with this agent. So it was already clear from earliest sort of modeling results that PIK3CA mutant tumors should be the first type of or subtype of disease that we should target with this agent. And this is the first in human trial of alpelisib, one of the first basket studies where any advanced solid tumor with PIK3CA mutation was eligible for treatment with this agent. As you can see, there was considerable activity, as shown on the right side of the plot. There were some rapid progressors, as shown on the left side of this waterfall plot. And then there was a whole group of patients in the middle that has some, where there was some activity, but not as much as we hoped for. So there was clearly a heterogeneity in the clinical response as we treated these PIK3CA mutant advanced solid tumors. And additional work was needed to understand why. What is it about PIK3CA mutant tumors, depending on the cellular context where these drugs are deployed, that is necessary for the drug to really have even bigger activity? And in this work by Anna Bosch, published now several years ago, what was really interesting to see is that tumors do not stand still. So when we give a PI3 kinase inhibitor, there is a compensatory activation of the estrogen receptor signaling by increasing the estrogen receptor levels and by increased pathway activity, as shown by increased levels of estrogen responsive genes, such as progesterone receptor. So it's not surprising then that the next step in development of PI3 kinase inhibitors is to combine it with another agent, in this case, a selective estrogen receptor degrader. There's one that's approved, fulvestrant, and it is that combination that was then pushed forward into the later phase of drug development. Obviously, different contexts will have different adaptive mechanisms, and it is not surprising that PI3 kinase pathway is sort of a poster child of disease-specific drug development. The context really matters, and we cannot deploy these drugs in any tumor expecting equal response. We really have to understand these adaptive responses and understand what the right combination is. So when we did combine fulvestrant with alpelisib, all of a sudden the waterfall plot looks different. Now you have a large number of patients actually responding as an objective response or prolonged stable disease. And median PFS in ER positive metastatic breast cancer treated with both alpelisib and fulvestrant is now 9 months, despite the fact that these patients have median 5 lines of therapy. Obviously, based on this result, it was then easy to move forward to the registration trial called SOLAR-1, which ultimately tested how alpelisib plus fulvestrant compares to fulvestrant plus placebo in ER-positive metastatic breast cancer. So this is the outline of the study. It should be noted that the studies had 2 different cohorts. One cohort with PIK3CA mutant with 341 patients. And there, the randomization happened to fulvestrant plus alpelisib versus fulvestrant plus placebo. And the primary endpoint of the study was the PFS in this cohort. There was additional cohort, a PIK3CA non-mutant cohort, which had somewhat different statistics, where fulvestrant plus alpelisib was also compared to fulvestrant plus placebo. And by this trial design, we can show 2 things. We can show what the benefit of alpelisib is, and we can also show the utility of PIK3CA mutation as a predictive biomarker in this patient population. Now, how did we test these patients? This is really, really important. In the trial itself, we tested tissue. As a matter of fact, majority of patients in SOLAR-1 had their primary tumors tested because this is what was available, okay? The primary endpoint was then determined based on tissue-based PIK3CA mutation status. Subsequent analysis have shown that we can also use plasma or circulating tumor DNA. And this is where we run a bit of a trouble with different sensitivities of these assays. So what's happening in the tissue? You can see that if you use the first companion diagnostic approved for this drug, so-called TheraScreen, real-time PCR-based assay, you're having limit of detection anywhere between 2 and 14%. This is okay for tissue, where tumor cellularity is often 30, 40, 50%. So if half of the genes in the tumor genome actually has the PIK3CA mutation, the mutation is heterozygous, and the cellularity is 30%, for example, half of that is 15%, that's okay for all of these mutations. Okay, so tissue is then able to detect presence of the mutation pretty easily. The problem now is when we use circulating tumor DNA. There, the main source of DNA in that material is actually the DNA from the white blood cells, where circulating tumor DNA may be only 1, 2, 3, 4, 5% of the total DNA. Since limit detection is now also somewhere between 1, 2% to up to 7%, now we're running into trouble, because if you're starting at just 2%, half of it is the mutant version of the gene, 1%, we are actually running into trouble, because that may be below limit of detection for some of these alleles. That's why at least when this assay is used and comes back with a negative result, we are not necessarily sure the tumor is truly PIK3CA wild type, and reflex testing in the tissue is often required to be completely sure about this finding. As per NCCN guidelines, this is actually shown in this slide, where if you use tumor tissue and the result is positive, yes, you can move ahead with treatment. If it's negative, it's negative. But if the liquid biopsy comes back as negative, you have this reflex testing that connects to the tumor tissue, and a repeat analysis on tumor is necessary to completely exclude or to be sure about that there is no PIK3CA mutation. Obviously, these algorithms depend heavily on the analytical characteristics of each assay. As a practicing oncologist, we really do have to pay attention. What are these analytical characteristics, so that we can understand when we should use tissue, when we should use blood. This is the primary endpoint. Ultimately, what was seen in the study, the median PFS in PIK3CA mutant cohort was 11 months, which was near almost double compared to 5.7 months in the placebo plus fulvestrant arm, which was both statistically significant, with the p-value seen on the right, and I believe clinically meaningful. A very interesting analysis is this one, where we are comparing how the combination performs in the first line setting. These are the patients who were treated with fulvestrant alpelisib as their first treatment metastatic setting. How is that possible? Well, those are the patients who are progressing on or shortly after, within first year of adjuvant AI treatment. So those patients are now getting fulvestrant alpelisib as their first line treatment. And then the true second line therapies on the right, where the patients are getting AI-based treatment in the first line setting, in the metastatic disease, and then they receive fulvestrant alpelisib as the second line treatment. What you can see here, how hazard ratio goes from 0.71 to 0.61. And what's happening is your experimental arm is performing equally well, approximately 11 months, but your control arm goes from 6.8 months to 3.7. So all of a sudden, as the tumors evolve and the pathway is fully activated, fulvestrant start performing somewhat poorly. And this is a bit of an important point, and we have to pay attention to the timing of our treatments. Just because we can match the right treatment to the right patient, that's still not enough. We need to decide what is the timing. Based on these data and based on our understanding of PIK3CA mutations as a sort of a permissive factor in activating the pathway, I generally use these agents mostly in the second line setting. Now, the OS overall survival was checked as well. While numerically there was a prolongation, we simply did not have statistical power to detect this difference, and the p-value was not significant. In a pre-specified subgroup analysis, specifically looking at patients with lung and the liver metastases, that numeric difference was even bigger, going from almost 23 months to 37 months. Okay, but again, the hazard ratio crossed 1, and we have to take this really with caution. What should be noted, though, it is clear that PIK3CA mutant advanced breast cancer patients with presence of visceral disease, their overall survival may not be very good, and we have to really look for additional treatment options precisely in this patient population. Now, going to that third learning objective of this presentation, we cannot just look at the left side of this graph, just the therapeutic effect itself. We need to spend considerable amount of time understanding toxicities, adverse events associated with inhibitors. It's precisely the difference between the two, that therapeutic window that we need to chase, and we need to ensure that it's as wide as possible. So this was so important for entire development of PI3 kinase inhibitor that I have prepared here a summary of different phases that the PI3 kinase inhibitors went through. Initially, we were very excited about using pan-PI3 kinase inhibitors that also hit mTOR, so-called dual inhibitors. They didn't really get far. Then we moved on to pan-PI3 kinase inhibitors, where we are now hitting all 4 isoforms. There, we didn't get too far either. Then we tried to spare the beta isoform and hit the 3 other isoforms. There, we had really some promising activity, but tolerability was very poor. And finally, by using an isoform-specific inhibitor that hits just alpha isoform, we're able to finally have that therapeutic index, and we're able to get both tolerability, or at least manageable side effect profile, and activity on the tumor itself. Okay, but there are multiple phases of development and multiple generations of PI3 kinase inhibitors. The most important so-called on-target side effect of PI3 kinase inhibitors is hyperglycemia. Why we would have hyperglycemia? Well, alpelisib, as a PI3 kinase alpha inhibitor, hits wild-type and mutant isoform of this enzyme equally well. Okay, wild-type isoform is important for signaling of insulin. So when you're blocking PI3 kinase alpha and insulin responsive or organs and tissues, you end up developing insulin resistance, which ultimately results in hyperglycemia. So there's plenty of insulin typically in these patients. What we have to do is reverse that insulin resistance with insulin sensitizers such as metformin to be able to interfere with this process and ultimately control hyperglycemia. Okay, so early recognition of this on-target side effect is critically important. Here I'm showing the dose modification guidelines for PI3 kinase alpha inhibitor alpelisib, and already with grade 1 event, typically in oncology, we don't necessarily care as much of these really low-grade events. But here, already at fasting plasma glucose of 140, we want to start or intensify metformin and then add additional agents such as SGLT2 inhibitors. So looking at hyperglycemia in the first few weeks of treatment and acting on it is critical to ensure wide enough therapeutic index and make sure that these patients can stay on therapy. Okay. Another important side effect is rash. There is what we have learned is very, very simple. If we use antihistamines, we can dramatically reduce the prevalence of grade 3 rash almost by, we can cut it in half. And all of my patients from day 1 of therapy have to get cetirizine or another antihistamine to be able to avoid as much as possible rash. So by careful selection of patients, ensuring that patients with who are not already overtly diabetic and have poorly controlled diabetes, as well as preventing the rash with cetirizine, by these two measures, as well as early recognition of hyperglycemia and management with metformin and SGLT2 inhibitors, we can actually make the tolerability profile of these agents pretty manageable. What is next? I'll just finish with a couple of slides showing the future of PI3 kinase inhibitors. I have already alluded to potential avenue that we can pursue to improve these therapeutics, since alpelisib hits wild type and mutant version of PI3 kinase equally well. There is a hope that if we develop PIK3CA and mutant selective agents, that we can achieve even wider therapeutic index. Wouldn't it be nice just to hit the mutant version of the enzyme in the tumor itself and leave the wild type version alone? GDC77 is one of these newer PI3 kinase inhibitors, and these agents has about 2 to 3x difference, where it does hit PIK3CA mutant protein a little bit better, but there are now even newer approaches to widen this selectivity to 10x or even more, and I'm quite excited about the prospects that these mutant selective inhibitors can bring to our patients. Now, another approach is to move away from PIK3CA itself and go down in the pathway and hit AKT as the next signaling node in the pathway. The proof of concept for this approach was established by Dave Hyman in this beautiful work with a AKT inhibitor used in so-called AKT17K mutants, where the first evidence of activity, clinical activity of these agents have been shown. And additional work has now combined these inhibitors with fulvestrant to show how combined AKT and ER inhibition can have a significant clinically meaningful effect on these tumors. It will be key to understand in which patients to use PIK3CA targeting, which patients to go ahead with AKT, and considerable translational research efforts are underway to understand this better. These are currently ongoing trials where we are now moving this even a step further. We're trying to, instead of picking ER plus AKT or ER plus mTOR or ER plus PI3K, we're trying to hit all 3 angles of that triangle with so-called triplet combinations. This is possible with GDC77 in combination with palbociclib and fulvestrant, or an AKT inhibitor called ipatasertib, which is also given with palbociclib and fulvestrant. The idea there is to hit the tumors early and to hit them hard. This is my last slide. We showed a sort of good problem that we are having in metastatic breast cancer. We need to decide how to sequence all of these treatments. If we start every patient with an AI plus CDK4/6 combination, and then we move this patient to fulvestrant plus alpelisib for PIK3CA mutant tumors, or fulvestrant plus or exemestane plus everolimus for PIK3CA wild-type tumors, that's certainly one option. The lower 2 scenarios where we are actually adaptively changing the combination even before radiographic progression by adding a PI3K/AKT/mTOR inhibitor, or even most promising potentially, where all three drugs are giving upfront. Those results we'll have to wait for and see what the trials will show. But I'm extremely excited because we know that hitting this tumor early, as long as we can maintain the therapeutic index, has potentially the biggest chance of preventing emergence of resistance and resulting in durable responses, maybe in some patients even in cures, but we'll have to wait for that. With that, I would like to thank you, and we'll have opportunity to go through questions as well.
Thank you so much, Dr. York, for this phenomenal presentation, a really tour de force of the development of PI3 kinase, which has really been elegantly displayed and discussed by you. We now have some time for some questions. There's a few that are coming in from the audience, so I'd love to engage in further discussion with you on these questions. So one question that came in for you, Dr. York, is, when should we test PI3 kinase? Should we test upfront along with hormone testing, respectively ones, with ER, HER2, PI67, or should we reserve for second line or beyond? If we're doing serial testing, you talked about ctDNA a bit. So can you just talk through for the audience your approach to actually testing?
Yeah, so that's excellent question, and critical as we discuss the timing of our interventions. We talk about precision oncology as giving the right treatment to the right patient, the right time. And for that reason, we need to, at every particular time point in the progression of disease, really understand what we are dealing with. My approach with assessment of these tumors using molecular profiling tool is to get all the information at the time of diagnosis. So in metastatic breast cancer, we have already made a major step in understanding that at the time of metastatic disease, we really have to rebiopsy disease at first to repeat the receptors. And this is the opportunity, using that highly cellular material, the tissue material, to also get mutation profiling results. Now, you can ask me, why would we do this in the first line setting if we already understand that AI plus CDK4/6 inhibitors are really the way to go? Well, I need to know more than just one line of treatment when I'm discussing the management of disease with my patient. I would like to know at least second and third decision that I need to make. So if something unexpected happens in the first line setting, where all of a sudden the treatment is much shorter than we initially anticipated, and we're under pressure to actually deploy the second line treatment much sooner, this is where it's wonderful to have all the data from the diagnosis that we can already give fulvestrant or alpelisib if PIK3CA mutant patient, or if they're not mutant, look for other treatment options. A very legitimate approach is to do receptor testing and tissue-based profiling upfront, and as there is further development of ctDNA assays, to repeat ctDNA-based profiling at the time of disease progression to see if there are any additional alteration that the tumor acquired as it evolves. Obviously, financial aspects of these testing strategies have to be considered as well, but in ideal world, this would be a very nice approach. Upfront profiling with as many tools that we have, and then serial profiling with blood-based assays.
Great, thank you so much. We'll wait for a few more questions from the audience, but since we don't have any right now, I actually have a question for you too. So you started to talk a little bit about combination strategies, and you talked a little bit about AKT as well, started to touch on sort of other nuclear hormone receptors. Where do you see kind of novel combination strategies coming, whether it's with DNA damage repair enzymes or immunomodulators? Once we sort of hit the pathway hard and efficiently with a good therapeutic index, where do we go from here?
Yeah, what we currently are lucky to have is a growing body of knowledge how various signaling nodes are actually wired together, how they interact, and what feedback loops are being activated as we target one member of the pathway or another. So we have a really nice sort of framework in which to develop new treatments. And we have already made major strides with anti-ER agent, PI3K, mTOR, and AKT agent are chasing really, they're really nearby, and they should enter hopefully clinic soon as well. What all of these treatments are based on is this interconnected network of events. But unfortunately, what can happen in cancer is various collateral pathways can emerge, or the tumor can be so heterogeneous that upfront it depends on series of other events beyond PI3K, AKT, mTOR, CDK4/6 axis. So we would desperately need additional agents that are sort of orthogonal to these signaling approaches, where cross resistance can develop very, very quickly. So we still desperately need other agents targeting sort of DNA damage pathways, novel antibody drug conjugates, where we can achieve much higher concentrations of chemotherapeutics in the cell by using sort of anchoring approach with an ADC. And I think we're going to have to learn very quickly from our infectious disease colleagues where these multi-drug combination treatments will be critically required to truly eradicate these tumors. I'm starting to hope as advances in drug development are continuing, that maybe, just maybe, this idea of cure in metastatic setting is actually possible. But it's not going to be sufficient for us to have just these rational drug combinations where we fully understand how all the signaling nodes interact with each other. We'll need to be a little bit irrational. What I mean by that is to combine agents that are from disparate components of this cell machinery, where cross resistance cannot reemerge as quickly, where one alteration, whether that's PTEN loss or another alteration, wipes all three drugs in the combination. So I think your question leads to a series of other therapeutic modalities and agents that we will carefully we'll have to carefully combine with the existing agents to actually achieve this really durable responses or perhaps even cures.
Yeah, I think you've beautifully highlighted the challenges of this acquired resistance and the challenges that we have as a field to sort of think about therapeutic strategies to overcome not only heterogeneity but acquired resistance. As a piggyback, I think we have time for one more question that came from the audience. A very practical question for you, then, which you alluded to a little bit when we're thinking about kind of other pathways forward. So, for your patients that are coming into the clinic who have failed a PI3 kinase inhibitor, you've potentially gotten your ctDNA results at that time too, at the time of progression. What are you doing next?
So clinical trials are by far the best approach for these patients, and they literally walk that triangle that I described. We now have a series of new agents targeting ER. We have selective estrogen receptor downregulators, sort of super fulvestrant, so to speak. We have SERCA, selective estrogen receptor covalent antagonists. And in some ways, emergence of resistance on these two upfront therapies is actually through ER, and better ER targeting is the way to go. On the PI3K side, we can go after AKT. And finally, on the CDK4/6 side, the RB axis side, we actually now have two new agents that can go after potentially redundant mechanisms in this part of the pathway, such as hyperactivation of cyclin E CDK2 axis. So we have CDK2 inhibitors, or we can use a whole new class of agents that block not just cell cycle CDKs, but these transcriptional effects with CDK7 inhibitors. So this is already 5 or 6 agents that we can deploy just in this within this triangle. Novel ADC, antibody drug conjugates, particularly those targeting TROP2, is a wonderful area of investigation. So clinical trials are truly, in my opinion, the way to go. Already in that second and certainly in third line setting, with a hope to delay initiation of sort of old school cytotoxic chemotherapy, unless the patient has visceral crisis or some sort of real convincing clinical criteria where chemotherapy needs to be deployed.
Great. Thank you so much for this excellent discussion. We really look forward to seeing where the field goes and where you take us next. So thanks again. So now we're going to shift gears a little bit, and we're going to move to a discussion that Dr. Jurek started to touch on a little bit, plasma versus tissue genotyping, which will be a live debate between Dr. Ryan Corcoran, who's the director of the GI Cancer Program, as well as Dr. John Iafrate. So with that, we'll just pause for a brief moment before we begin our debate. And just to briefly reference for you all, there's learning objectives, which we have outlined by the two presenters here. So welcome, Dr. Corcoran. Welcome, Dr. Iafrate. It's a pleasure being here with you both this morning. And really excited to engage in this discussion with you. So, before we begin, I'd just like to sort of give a brief introduction to sort of cell-free DNA and applications. And, we are using cell-free DNA as well as tissue in a host of different applications. Cell-free DNA, we're looking at it in terms of genomic profiling, looking at drug resistance, as well as increasingly in the MRD setting. We only have now less than sort of 20 minutes to discuss today. So for the purposes of today's discussion, let's really think about kind of current applications in terms of genomic profiling for patients, either at the initial time of diagnosis as well as kind of over the course of the treatment approach. Dr. Corcoran, whose lab does a lot of actually, both labs do a lot of cell-free DNA work, but Dr. Corcoran is going to be taking the pro-plasma side of this debate, and Dr. Iafrate is going to be taking the pro-tissue side. So since the gold standard is tissue, I'm going to let Dr. Iafrate sort of kick off our discussion, and then we'll let Dr. Corcoran piggyback on that.
Thank you, Aparna. Thank you for the invitation to be here. Yeah, I agree that tissue should be considered the gold standard. Obviously, we have the most experience with tissue. I'm a trained anatomic pathologist, so I also see some QC issues in having tissue. The ability to see under the microscope and verify what type of tumor it is and what tumor percentage, the quality of the material, is there necrosis, are there other issues that might come up that would affect the interpretation of that? Some things you can only see under the microscope and confirm in the pre-analytical phase that you have a high quality sample. So I like to think at that stage that tissue should be considered the gold standard. Now, understanding that patients, and I think Ryan will get into this, some patients, it's difficult to biopsy them, or put it the other way, it's much easier to obtain a blood sample than it is to get a biopsy. If Ryan's okay, I'll kind of outline where I think tissue shines, and then let him discuss where cell-free shines. There are several genetic alterations which are much easier to detect, much more reproducible to detect in tissue, and that includes gene fusions and copy number variants. Single nucleotide variants, point mutations like Dr. Jurek described in PIK3CA. I think cell-free works quite well. He pointed out in breast cancer some of the limitations, and I would say breast cancer actually is one of the easier tumors in the metastatic setting to detect cell-free because they shed a fair amount of cell-free DNA. Other tumors don't shed as much as breast in my experience. So even point mutations, which I think are probably neck and neck between the two approaches, you might in certain tumor types give the advantage to tissue just because of the amount of material that's shed into the bloodstream. But for gene fusions, it's very, very difficult to put up tissue versus gene fusions. One issue in blood is there's not a lot of cell-free RNA, or there's essentially, in our experience, no detectable cell-free RNA. You might find some in a circulating tumor cell or in an extracellular vesicle, but you're not going to find it in circulation. So mapping gene fusions can be done from DNA, and some of the companies that are in this space do map gene fusions using the short fragments of cell-free DNA, but not as robust as in tissue where you can use RNA for mapping fusions, which in our experience is much more sensitive and much more accurate. Copy number variations you can absolutely detect in cell-free, but is much more difficult. I won't go into HER2 in breast, which is its own hour-long discussion about the analytical approaches to that and the accuracy. But it'd be very hard in that setting to move from HER2, where we use FISH or IHC, into a cell-free application. In our experience, you need a certain tumor percentage, tumor fraction in plasma to accurately or sensitively detect copy number variations. In our hands, it's about 10% tumor fraction, which, as Dr. Parikh and Corcoran can say, is not that often that you see tumors at that high tumor fraction in circulation. So if you have less tumor in circulation, you can have a harder time reproducibly detecting copy number variations. There are, in my mind, there are a couple of ways to think about the analytical drawbacks of cell-free, and I think Dr. Jurek pointed them out. The way I think about it is that cell-free has a really good positive predictive value, and that is, if you find the mutation or you find the alteration, you can be pretty confident in it. I would qualify that statement by saying that the allele fractions or the tumor fractions, to be confident, generally have to be higher than 1%. That's not absolutely true. There are many tumors that we follow that you can detect known mutations under 1%, accurately follow them. There are only a few publications comparing different platforms, but the few that have been published certainly show that some platforms, or the majority of platforms, begin to fall apart under 1%, where you can be very confident in both the positive predictive and negative predictive value, sensitivity and specificity. So having a higher tumor fraction is important for accurately detecting all those things, and that's where I think tissue shines. Obviously, great benefits for cell-free, and maybe I'll pass it over to Ryan now to tell me why cell-free is much better than tissue.
Great,
All
Dr.
right,
Corcoran.
thank you. So, yeah, good morning, everybody. It's a pleasure to be here. I'm looking forward to a fierce debate with my friend John Iafrate. So I'm taking the pro-plasma position today, and I think that plasma cell-free DNA clearly offers a phenomenal opportunity to, in a minimally invasive manner, through a simple blood draw, to actually assess many levels of the cancer genome to get a lot of the critical genomic data that we need to make treatment decisions. And the fact that that can be done rapidly through a simple blood draw is really a huge advance. So the question is, when are the best times to use plasma versus tissue? And I'd like to frame this debate because I think that arguing that plasma should replace tissue biopsy entirely, I think, is probably not an appropriate thing to claim. I think that John is right that there really isn't any replacement in the near future, I think, for a blood-based test over an initial tissue diagnosis, to confirm that it is cancer. What type of cancer? Clearly, by definition, circulating tumor DNA can only really detect DNA-based mutations. So things like estrogen receptor expression, other protein markers are just simply things you can't detect through cell-free DNA. But I think the questions that are worth asking are, number one, should we test circulating tumor DNA at baseline, even if it's in parallel with a tissue biopsy? I think that's an important question. And if we do that, is it okay to act on the results of ctDNA and actually start treatment based on ctDNA results, even if the tumor testing isn't back? And I'd argue that in many cases, the answer was yes to that. But then a second question is, after a patient has received treatment, particularly targeted agents, which drive the clonal evolution of cancer and often the emergence of not just one, but multiple resistance mechanisms. I'd almost argue at those subsequent time points that plasma might be the preferred method rather than a repeat single lesion tumor biopsy. And so let's take those questions in kind of in order. So my sense is that it is a good idea, particularly when you think there's a high chance of a patient may go on a targeted or investigational therapy to test ctDNA at baseline. Now, why is that? Well, number one, I think if you're going to test again and use it to understand how the tumor is evolving, it's nice to have a baseline. But more importantly than that, actually one of the key strengths of plasma DNA is that certainly it can be assessed in patients where a biopsy is very tricky, where it's a small lesion, maybe an unsafe area to biopsy. I think that's a very obvious use. But actually, the turnaround time is a big highlight. From the time you see your patient in the office, you can get blood drawn that day and have results in 7 days. And even though times for various molecular tests on tissue can be somewhat quicker, there was actually a really interesting study in Nature Medicine published by some Japanese colleagues of mine who compared screening for clinical trials with plasma versus tumor. And what they found was that the genomic data came back in about 7 to 10 days on average with plasma and about 3 to 4 weeks on average with tumor. And as a result, the enrollment to a matched therapy trial was actually double in the plasma group what it was in the tissue group, solely for the reason that investigators had the results in hand and were able to act on it in a reasonable amount of time. In many cases, those who had already used the bite the bullet and go on to another therapy. So I think purely for speed, if a patient needs to get started on treatment soon, I think that's a big push to get plasma at baseline, particularly in the case of, say, a non-small cell lung cancer patient and a non-smoker, where identification of an EGFR mutation or similar might allow you to drive treatment. But kind of the second question is, if you had a patient who's had a nice response to a targeted therapy and has been progressed, should you do a repeat tissue biopsy? Or is actually plasma, I'd almost argue, the preferred method here? Now, why would it be the preferred method? Number one, it's minimally invasive. You're not putting a patient through a second procedure. But the key issue is the concept of tumor heterogeneity, that we're finding more and more now that patients don't just develop one uniform resistance mechanism throughout all their cancer cells, that patients can develop 2, 3, sometimes 9, 10, 11, 12, 13 mutations in different subclonal populations spread throughout the body. And actually, Dr. Parikh published a very nice study in Nature Medicine about 1.5 years ago that showed that if you compare time-matched post-progression liquid biopsy with post-progression tumor biopsy, you find additional clinically relevant resistance mechanisms that are not picked up in the matched tumor biopsy in about 80% of cases, at least in GI cancers. And so this concept of heterogeneity, if you're just tracking what's going on in one part of one specific lesion where your needle went in, you may end up chasing kind of only a small, what's causing resistance in a small fraction of the tumor population. And when we do this, we find that we often at best get a mixed response. So I'll stop there and allow John time for a hearty rebuttal.
I think we can agree to disagree. I'll come back to the positive predictive value comment. I think in the study you mentioned about clinical trials, I think in the setting of clinical trials, PPV is probably all you really care about, right? When you're setting up a clinical trial, you want to have a sensitive and specific test, but really what you want to know is, for the patients who are positive, are they really positive going on to a targeted therapy? And so it really, I think cell-free makes a whole lot of sense if you're setting up an infrastructure to put patients on clinical trials. The question, I guess, comes back, as Ryan mentioned, what do you do with a negative cfDNA result? Maybe testing up front, as he said, makes a lot of sense. We're not going to really talk about cost or payers or cost to the system, healthcare costs, but that eventually will, I think, come into play about how much can we get approved. Right now, I think most payers are paying for cell-free DNA and tissue, but I assume over time that will change, and we'll have specific guidelines about when we can do these. But I think we agree on how you would use this and when you would use this. And I think folks in the audience just need to understand the performance characteristics of the test they're using, especially in the disease in which they're looking, to not get either a false sense of security about any of the cfDNA results.
So that's fantastic. I have a question, but I'm going to reserve my question actually, since a question came in from the audience. So for both of you, where does early detection approaches via cell-free DNA come into play? We're seeing lots of different players in the space: Grail, Freenome, others. So that's the first question. And then the second question is from both the genomic end as well as the RNA end. How are you all comparing, Guardant's approach with upcoming approaches like Caris's whole exome liquid panel? Both are claiming an ability to actually, capture fusions and rearrangements as well as copy number alterations, with Dr. Iafrate mentioned was a key limitation of cell-free approaches. So if we could touch on that, and then there's a question also on Medicare reimbursement. So we'll save that after we sort of talk about early detection, as well as kind of Caris and Guardant and an ability for copy number changes as well as rearrangements.
Right. I mean, I'd be happy to quickly start maybe with the early detection question. Sorry, John's a delay. I didn't mean to cut you off. I know there's a lot of questions in very few minutes, so we'll go quickly. I think that we're all very excited about the potential blood-based early cancer detection approaches. I think that's something that is a little different from the topic today, because you can't really have a tissue versus blood debate over early detection because there's no tissue to be had. But this is something that there's some really interesting results, at least in known cancer patient cohorts, which I would argue are a little easier to detect than, because those patients came to clinical attention, due to symptoms or, and a larger than normal tumor causing symptoms. I think that when you transition that to a real screening population, it gets a little tougher, and you likely can expect some of the performance to go down. But I do think that again, even if we're detecting maybe a third or half of cancers early, and giving a good majority of those patients a chance for cure, that's a big thing. And we don't need to be perfect to start having an impact here. So I think that's a very exciting area.
Great. Maybe Dr.
I would. Yeah, about the fusion copy numbers. Again, I think it comes back to positive predictive value. If you have a finding that looks confident with a high enough allele fraction, I think you can be confident that that's a true result, especially from the companies you mentioned, who I think have put a lot of work and effort into the validation of their platforms. What's the sensitivity of those tests? I think you'll find, depending on the fusion type, they can be quite low. And the DNA approach is a complicated one. You actually have to sequence the introns of these genes, which can be quite large and quite difficult to sequence without going into details about how you sequence through repetitive DNA present in introns. It can be quite challenging. So again, I think you can use those platforms for sure, and if you get a confident result, you can act on it confidently. But what does a negative result mean? I think those kind of studies more studies like that need to be published, and not a lot, to be honest, have been published about them. But in our personal experience, I know.
And I'm sure this is sort of a little bit beyond the scope of this, but the fusion partner probably matters too. And so, if you have a fusion partner that's sort of well known and characterized, it's easier to obviously kind of bait for that, rather than emerging other fusions that we're learning about, where there's a whole host of different fusion partners, which may be a little bit harder to bait for. So just a sort of aside there.
And the lower the tumor fraction in the sample, the harder it is to call anything, to be honest. So.
Great. So I think the last question we'll probably have time for today is, I think, an important question, which we've sort of briefly touched on in terms of the healthcare system cost. To date, is Medicare paying for both liquid and tissue at diagnosis? John, you may have a better sense.
Yeah, I mean, I know in our region, yes, but we've negotiated with our local Medicare contractor. I'm not an expert in each of the contractors in each of the regions of the country, but more and more, yes. I think most, especially for FDA-approved platforms, Medicare will cover cell-free. Certainly, they're covering tissue, of course.
Yeah,
I think much of that is also what is the field like now, and where will we be? And I think certainly liquid biopsy is kind of finding its niche. And I think if there are more studies, I think like the Japanese study that show the benefit of liquid biopsy and matching therapy early, or at baseline, you could certainly see if the test is less likely to get covered now, it may become more likely to be covered in the future, but we'll see how that develops.
Yeah, and I think for now, nicely, a lot of the companies have very generous patient assistance programs to help offset. So the cost is still low for the patient if the patient does indeed get a bill. So with that, we are at the top of the hour. It's 9 o'clock. I wish we had 2 hours for this debate, and we only got to briefly just talk on genomic applications, but there's a whole host and really exciting field and emerging data in this space. So thank you so much for your time today, both of you, and thanks again to CEO and the MGH and the Chapner collaboration for hosting this wonderful conference.
Great. Thanks a lot.
Thanks, Aparna. Thanks, Ryan.